Hey guys, so let's talk about differentiating GI disorders tonight. So this is going to be just a quick run through of all the major GI disorders. So let's start with nausea, vomiting. So what's really the problem with nausea, vomiting? With nausea, even though there's nothing coming up, with nausea, a lot of times comes vomiting. So the concern is going to be for losing gastric acid, which can lead to acid-base imbalances, da, da, da. So we're also worried about the patient not getting the nutrients that they need or being unable to eat. So, our big concerns are going to be fluid and electrolyte imbalances. And then also, like we talked about, those acid-base imbalances. So since you vomit acid, then we're going to be worried about metabolic alkalosis because you're getting rid of all the acid. So all you're left with is your base. So what are we going to do about it? We're going to replace what is lost, the fluids, et cetera, electrolytes. Because of the risk of electrolyte imbalances, we're going to monitor their EKG and heart rhythm closely. And I'm going to be there to support their nutrition to try to make sure that they're getting their needs met. All right, this is going to be fast and furious, so it's going to be a lot of different ones. So definitely get your bootstraps ready. So how about GERD? So the problem in GERD is the sphincter or the door to the stomach is weak. So in other words, the door that's in between your esophagus and your stomach is weak. And because it's weak, food and acid start moving backwards, which leads to a lot of uncomfortable symptoms. So I'm really going to be worried about respiratory complications because they can have a higher risk of aspiration, and then also tissue complications. Because they can have, breakdown of their esophagus, what's known as Barrett's esophagus, which can lead to cancer. So what are we going to do about it? I'm going to give them medications that are going to help them to decrease their acid toll as a whole daily. I can also give them medications to help buffer acid after they eat. And then changing their lifestyle and meal routine can also make a big difference. Remember, these are not all inclusive. This is not the only concerns or the only big things, but these are some of the major ones to start considering as you're differentiating these. So hiatal hernia. What's the problem here? There's a weakness in the diaphragm and the stomach pops above the diaphragm. So a lot of times, and I have a different PowerPoint that's going to be about breaking down the difference between one and another. And a lot of people get this mixed up with GERD because hiatal hernia has a lot of symptoms of GERD. But the difference here is that it's not that that door what we call between the esophagus and the stomach is weak. It's that there's a weakness in the diaphragm. And so the stomach actually pops above the diaphragm, which leads to those reflux symptoms. Again, same stuff, respiratory and tissue complications. I can do surgery, not me, but a doctor can do surgery to fix that weakness. Again, decrease the acid daily with medications, buffet acid after the meals, and changing their lifestyle and meal routine can also make a difference. How about acute abdominal pain? The big problem is that acute abdominal pain can be a sign of a very big problem. So a rigid abdomen is my scary, scary sign when it comes to GI problems. And so I'm going to be worried about perforation and peritonitis. In other words, that can lead to sepsis and death, lots of very, very scary things. So, what am I going to do about it? This is a very general thing. Acute abdominal pain isn't really a disease or disorder. It's really a symptom. But the big action that I want to take is find out where's the pain, because where the pain is located is going to tell me a lot about what's going on with the patient. And then after doing a good assessment, I'm going to contact the physician. Now, if I walk into a room, patient's there for a GI problem and their abdomen's rigid, that's the only information I need. I'm going to go, and contact the physician. But if I go in and a patient just says, hey, I'm having abdominal pain, I'm going to do a full assessment. Where is the pain? What is it like? What makes it better or worse? Doing that full assessment. Let's talk about pancreatitis. There's acute pancreatitis. So that's where pancreatic enzymes are getting released and eating the pancreas. Then there's chronic pancreatitis where the pancreas gets fibrotic or gets really thick and hard to, it's not doing the same, it doesn't have the same functions because the tissue is all fibrotic. It gets inflamed and it cannot release enzymes. So actually acute pancreatitis, I have too many enzymes. In chronic, I can actually have decreased enzymes because they kind of get, your pancreas loses that function. I'm really worried about infection. These pancreatic enzymes, especially in acute pancreatitis, think of them like Pac-Man. They're going around and they're chewing and chomping on everything. They can lead to a lot of inflammation. So especially look for respiratory complications. And they also can have impaired nutrition because a lot of time, well, if a patient has acute pancreatitis, they are NPO, nothing by mouth. So there can a lot of times be a decreased nutritional, we call it support, there's decreased nutrition for that patient. And then chronic, because they don't have pancreatic enzymes or they're low on them because of that fibrotic tissue, then they can also have trouble breaking down and digesting foods properly. So what are we going to do about it? So like I mentioned for acute, with the patient with acute pancreatitis, this is like serious business. And I should probably add here that one of their big worries is going to be pain, because acute pancreatitis is so painful. And so we use, we call it opioid analgesics. They usually get all their medications IV because they're NPO. We don't want to put anything in their belly. Anything we put in their belly is going to stimulate the pancreas to say, hey, make some enzymes. And that's going to make the problem even worse and increase their pain. So nothing by mouth. IV fluids, hydration is going to be so key for these patients. That pain management, like I said, those opioid analgesics, IV meds, and then support their nutrition. A lot of times these patients are going to get those feeding tubes that go all the way into the duodenum, so that they're at a decreased risk of having those pancreatic enzymes getting released, because we pretty much will put the tube past where there's like the sensor that's telling the pancreas, hey, secrete some more enzymes, so that you're not having that problem, but still getting the nutrition you need. And in chronic pancreatitis, we're going to replace their enzymes and then watch for complications, like these patients can be at higher risk for diabetes and stuff like that. So how about coli problems? So the two coli problems we talk about, there's cholelithiasis and cholecystitis. So cholelithiasis, when you see lithiasis, always think stones. And since it's cholelithiasis, it's stones in the gallbladder. Whereas cholecystitis is inflammation of the gallbladder. And the difference there is cholelithiasis, think more like blockage, and cholecystitis, it's more of an inflammation, infectious process. So I'm going to be most worried about infection. For cholecystitis. For cholelithiasis, I'm going to be more about blockage. And I kind of differentiate those a little bit more in that differentiating GI video, if you want to watch that one. I'm also going to be worried about managing their pain and supporting their nutrition. For cholelithiasis, I can go in and do procedures to remove stones, place stents in, allow for those things to come unblocked. For cholecystitis, I can remove the gallbladder. I want to manage their pain, support nutrition and hydration, and really get them up and moving, we call it after they have their procedures. A lot of diet changes, after they get their, to help prevent them from having more problems with their gallbladder. So let's talk about appendicitis. Appendicitis is an inflammation of the appendix. My biggest concern with this is that it's going to perforate and they're going to get peritonitis, which is that infection, sepsis, very, very deadly process. So, the most common thing that's done for your appendicitis, we very rarely just watch it. 9 times out of 10, we're going to remove it. I want to support their hydration. They can have a lot of nausea and vomiting with appendicitis. So you would definitely want to support their hydration, watch their electrolytes and replace those as needed, and then doing good pain management for them pre and post-op. So how about polyps? So these are growths in the intestines, usually they're in the colon, and they're really harmless most of the time, but we always have to keep an eye on them because, they can become or be cancerous. And so we want to be watching them closely. And so when people have their regular colonoscopies to scan for colorectal cancer, sometimes we'll biopsy them. Most of the time, like I said, we don't really do much. We just kind of watch them. And then especially if there's a bunch of them, we'll usually be checking them out for cancer. So let's talk about peptic ulcer disease. So what is this? The problem is that, one second. The problem is that the stomach gets irritated and ulcers form, and they can form either in the stomach or in the duodenum. And so, the biggest things I'm worried about when it comes to an ulcer is that there's going to be bleeding. And then also on the other end of things, that wall can, that ulcer can erode so bad that there can be perforation and then peritonitis. And so, what do you call it, as a whole, like we're going to be looking out for those changes in hemodynamics, any sign of bleeding, like bright red blood that they're vomiting, or any signs that they're having infection, that perforation and peritonitis. And so for this, I'm going to treat it a lot like we caught a lot of the gastritis and the GERD, like we've talked about, decreasing acid daily, buffering acid after meals, changing their lifestyles and foods. Especially stress is a big factor in peptic ulcer disease. If needed, we'll do surgery, to help to remove part of the stomach if there's really bad ulcerations. And a lot of times peptic ulcer disease is caused by infection, like the H. pylori infection. So they may be receiving that triple or quadruple antibiotic therapy. So speaking of which, gastritis, we just talked about peptic ulcer disease, which is where they have ulcers, whereas gastritis is just where they have irritation or inflammation of the stomach, or the small intestines. And effectively, the thing to keep in mind is that it can lead to ulcers. We want to do all the same things that we mentioned previously in peptic ulcer disease, decreasing acid, buffering the acid after meals, changing lifestyles and food, decreasing stress. A lot of gastritis is caused by H. pylori, so they may need that antibiotic treatments that I mentioned. But one thing to keep in mind is that gastritis can be acute or chronic. And if it is chronic, they may need vitamin B12 replacement because they're going to not be producing intrinsic factor because the cells are so inflamed and irritated. They're not producing a really key cell that they're going to need in order to be able to absorb vitamin B12 the way that they need to in order to get it in. So like pretty much effectively the stomach cells secrete something that's kind of like think of it like a driver to get vitamin B12 absorbed into the body. And so without that driver or that key to the door, vitamin B12 can't be absorbed. So then there's gastroenteritis. So think stomach fluid when you're thinking this. So this sounds a lot like gastritis, but it's gastroenteritis. And so this is more of an infectious process. It can be contagious. It's usually caused by a virus. It's usually pretty self-limiting. But if there is an infection that's like bacterial, we can give antibiotics. We're going to support hydration because there's usually a lot of nausea, vomiting. Make sure their electrolytes are in balance. And then, just if there's certain foods or places that you're going to eat that are triggering it, we definitely want to avoid those people, places, things. Should say people. Hopefully you're not getting gastroenteritis. Well, maybe if someone else has it, but I was going to say hopefully someone that you're with isn't causing you to get gastroenteritis infection. Yes. So how about pernicious anemia? So what's the real problem here? This is what we talked about a few minutes ago when we were talking about chronic gastritis and maybe needing vitamin B12 replacement. And pernicious anemia, which happens in patients that have had gastric bypass, patients that have had part of their stomach removed or have issues with their stomach where the cells are broken down or aren't working the way they're supposed to, they have a loss of intrinsic factor. Again, that's that part of the stomach cell that is released that actually allows you to absorb vitamin B12. So, what happens there is that then chronically you can't absorb. So there's no way, if I have pernicious anemia and I've maybe had a gastric bypass or had gastritis and part of my stomach was removed, whatever the reason might be, I'm never going to be able to orally absorb vitamin B12. So I'm going to need vitamin B12 injections for life. And usually they're given IM for life. And of course, I'm going to be worried about side effects of anemia because vitamin B12 is a part of what makes up your red blood cells. Let's talk about diarrhea. So diarrhea is pretty, I was going to say commonly understood. Hopefully it's not too common for you, but it's loose liquid stool. And of course, we can think about if the concern could be that there's infection like C. diff, but the biggest concern we usually worry about is skin breakdown. We can also have like fluid electrolyte imbalances and things like that. And, we talked about with, with vomiting, we're worried about metabolic alkalosis, but with diarrhea, and I forgot to include this on the slide, we're worried about metabolic acidosis because we vomit acid and we poop base. So if I'm losing all my base, I'm going to be more acidic. So patients that have diarrhea are at risk for metabolic acidosis. And so what we're going to do is we might give medications to bulk up the stool. So bulk forming medications like Xylem, like think Metamucil. We want to replace the fluids and monitor those electrolytes and that acid-base balance closely. We want to protect the skin barriers, use incontinent devices if it's indicated. Change your lifestyles and your foods. And if it's C. diff, we want to make sure to treat that with the correct antibiotics and also do the special isolation precautions. So let's talk on the other end about constipation. This is hard to pass stool or inability to defecate. So we're worried about impaction, like a complete blockage. We're worried about hemorrhoids. And then also the fact that they can vagal down and pass out because they're straining so hard. So I want them to increase all their Fs, fibers and fluids, and really want to get them moving. Ambulation, movement, activity is really going to be helpful for these patients. I want them to change their lifestyles and their foods if there's things like that that's affecting their ability to have normal stools. I want to give them medications to help either lubricate or pass their stools, and there's a variety of them. You can check out the GI medications PowerPoint to learn more about this. How about diverticulosis and diverticulitis? So diverticulosis is fairly harmless, where there's pockets in the bowel, like, maybe you think of it kind of like hemorrhoids, but on your intestines on the outside. And so there's too much pressure and these pockets form, and they can be mostly harmless. But what happens sometimes is it forms into diverticulitis, where the pockets get inflamed, like things can get stuck in there and get inflamed, and can lead to some very serious symptoms. That inflammation can lead to perforation and peritonitis. It's too much pressure. Anything that causes pressure in the abdomen, we're not a big fan of. So for diverticulosis, for most of the time, you just have the pockets. They're not inflamed. They're just there. We want to change their lifestyle and foods and really increase their fiber so that things aren't sitting around and just hanging out in those pockets. Really get things moving. For diverticulitis, we want them to be NPO, nothing stimulating their bowels, no enemas, no, excuse me, hold on a second. Let me get a drink of water. Nothing, to stimulate or move their bowels. They're going to be resting. And we don't want to do anything that's going to lead to that perforation or peritonitis. So, when there's that acute inflammation, effectively, they're going to be on strict bowel rest. So other hernias. So we talked about a hiatal hernia. There's other hernias like inguinal hernias, umbilical hernias, etc. And the problem is that there's weak muscles. It just depends on, of course, where the hernia is. Like for the hiatal hernia, it's the diaphragm, etc. But weak muscles lead to tissues going where they're not supposed to be, is effectively a good way to understand it. I'm worried about strangulation. So in other words, like tissues are going where they're not supposed to be, and sometimes they fit in a little hole and then they get pinched off and strangulated. And it can lead to infection, perforation, peritonitis, sepsis, shock, death, all the scary stuff. And so usually we're going to do surgical repairs. We're going to avoid things that are going to cause straining, and we're going to monitor closely for complications. Bowel obstruction. So the problem is there's a blockage in the bowels, and we're going to be worried about, of course, there's a blockage means pressure. And so we're worried about pressure. We're worried about perforation and peritonitis. And so I'm also going to be worried about fluid, electrolyte, and nutritional imbalances as well. Because like I put down lower, what we're going to do about it, this patient's going to be NPO. They're going to be getting IV fluids. They're going to have an NG tube, but not for feeding or food or meds or anything. It's going to be to decompress their stomach. We want to support adequate bowel functioning and really try to, hopefully things will start to get moving as we start to rest the bowel and give it a chance to heal. And we're going to monitor their electrolyte levels, since they're not going to be taking in good intake, so that we can help support them so that they don't have imbalances. Yeah. Sorry, my cat wants to be a part of the presentation. So let's talk about Crohn's disease. So Crohn's disease is an inflammation in the bowels all throughout. So Crohn's disease is one of the types of inflammatory bowel disease. And I talk about the differences between the two more in my this versus that PowerPoint. But effectively what it is it's an inflammation that's happening. It happens on all layers and all layers and all sections of the bowel, most often in the small intestines, or small bowel, but it can go all the way through the colon. It can lead to perforation and peritonitis, because remember, inflammation, think inflammation, pressure, perforation, peritonitis. And malnutrition is really common, because since this affects the layer, like it's an inflammation of the area of your stomach where you're doing a lot of absorption, area of your intestines that you're doing a lot of absorption, then we have to be worried about you not getting adequate nutrition. So what are we going to do about it? We're going to give medications to decrease inflammation, medications to decrease your immune response, because this is considered an immune disease. And lifestyle and food changes, we go on what's called a low residue diet. So stuff that's not going to hang out in your intestines for what we call a very, very long time. And then support nutrition, make sure that they're getting adequate nutrition, because patients with Crohn's are more prone to that chronic malnourishment. So how about ulcerative colitis? This is an inflammation in the bowel, except it's mostly in the, only in the innermost lining on the inside, and it's mostly just the colon, which is why it's called ulcerative colitis. So I'm gonna be worried about inflammation leading to perforation and peritonitis, because again, inflammation, pressure, perforation, peritonitis. And then also with ulcerative colitis, it's really common for that inflammation to lead to bleeding. So these patients can have hemodynamic instability. So again, I'm going to give them medications to decrease inflammation, medications to decrease immune response, lifestyle and food changes, that low residue diet, and then monitoring their fluid electrolytes and hemodynamics, monitoring that hemoglobin, checking for signs of them bleeding internally. These patients can have up to like 8 to 10 stools, and they can be bloody stools a day. So they can be losing a lot of blood, even if they're not bleeding a lot with each stool. It cumulatively can build up. Let's talk about hemorrhoids. Again, too much pressure, but this one, it's in the rectum. So usually there's not the perforation and peritonitis that we worry about as much, but it's always possible. We more worry because of the location about infection and altered skin integrity. And there's a lot of pain and discomfort associated with these as well. We can give medications to treat the symptoms. We can do what are called sitz baths, which help to soak those hemorrhoids. We can do lifestyle and food changes, increase the fiber. We can also increase their fluid intake to help to decrease that the hardness of the stool, and then encourage no straining, because that straining is a lot of times the forcing of that is what can cause hemorrhoids. And like we talked about in my class, get that squatty potty and get something in the right position. Make sure that you're this also goes for constipation. You want to be in the right position to stool so that you're not straining so hard. Now let's talk about anorexia. So the problem here is that they're starving themselves. They pretty much have this idea in their head that they cannot gain 1 pound, that they're going to go to whatever length that it takes to maintain their weight or body image. And they have a very false image of themselves. It's not just that they're like, hey, I just want to be healthy and be skinny or whatever, but even when they're at a healthy weight, they can't see and they still see fat. Like you can look at a person and be like, oh my God, they're skin and bones, but they see tons of fat everywhere. And so it's a self-image problem, and then it's also can lead to a lot of problems like malnutrition, fluid and electrolyte imbalances as well. We're going to give them nutritional support if they will accept it, and then lots of psychological support. On the other end, there is bulimia, which is where these patients, they have a similar problem where they're very obsessed with their weight and their body image, but they end up binge eating, but then feeling guilt, shame, remorse, and then trying to restrict to manage, whether through exercise, through diet pills, through diuretics, through laxatives, you name it. There's lots of different ways that they try to restrict to manage that. So compared to anorexia, which I talk a little bit more about this in my this versus that video, they're actually eating food and but then just trying to get rid of it after eating it. So we're going to be worried about malnutrition, fluid and electrolyte imbalances, and tissue integrity issues because they're vomiting. A lot of these people are vomiting to manage that weight. They're throwing up right after they eat. They can have issues with their teeth and their mouth. So definitely be looking for signs of breakdown there. They could also have some acid-base imbalances from all that vomiting. They're going to be in a metabolic alkalosis, if you remember. So yes, so nutritional support, monitor their tissue and support tissue and skin integrity, especially in their mouth and face, manage that fluid and electrolyte balance, and lots of psychological support. Last but not least, obesity metabolic syndrome. This is where your weight is beyond requirements. and it leads to complication. You have to meet certain criteria to qualify for metabolic syndrome. But obesity, effectively, we're going to be looking at the problem being that there's so many more complications and risk for problems when you're obese or have metabolic syndrome. So we need to be watching out all body systems, but especially, the respiratory system can have a lot of complications. And there's so many risk factors for many problems. So I'm going to be needing to check all of their body systems for problems like diabetes, heart disease, a lot of I was going to say stroke and other cardiovascular diseases, but there can be problems in any body system. That's the other one, musculoskeletal joints and other problems. So I need to be watching and monitoring for those complications, supporting healthy lifestyle changes, giving nutritional support and psychological support as well. All right, that's it. I know that was a lot, but hopefully it will help to get you started to differentiating some of these if you found any of them confusing or found them hard to understand. This is really just a basic. Remember, this might not be everything. I will tell you, this is not everything you need to understand about every single one of these, but maybe helps start to break it down if you're a little stuck. There'll be other PowerPoints to come, so check them out. I'll see you next time.